Small cell lung cancer is an aggressive disease with a dismal 5-year survival rate. However, after decades without any significant improvement in outcomes, we are beginning to see progress with immune oncology-based combination therapies. In this OncLive peer exchange discussion, my colleagues and I, all experts in the field of thoracic oncology, will discuss current treatment approaches for small cell lung cancer and emerging strategies. I am Dr. Naiyer Rizvi, Professor of Medicine and Director of Thoracic Oncology at Columbia University Medical Center. Joining me today on this distinguished panel are Dr. Taufeeq Owonikoro, Professor at Emory University at the Winship Cancer Institute, Dr. Tiziana Leal, Assistant Professor at Carbone Cancer Center at University of Wisconsin-Madison, as well as Dr. Jamie Chaft, Associate Attending Physician at Memorial Sloan Kettering Cancer Center in New York. Thank you so much for joining us. Let's begin. So we're going to go through a discussion of how we approach small cell lung cancer, initially discussing extensive stage, how we approach the patient, how we incorporate immunotherapy into our treatment paradigm, and then talk a little bit about limited stage disease, and then some of the other treatment options that are available. Starting with you, Jamie, maybe you can discuss how you approach a small cell patient that you see in your office.
Sure, thank you. So the issue with our small cell patients, more so than our typical patients with non-small cell lung cancer, is that universally these patients are quite sick, and most of them have been heavy smokers. Therefore, they come with a list of comorbidities that we have to address in the clinic. The most pressing issue with most of our small cell lung cancer, particularly extensive stage, is how sick they are and how quickly we need to get things squared away for treatment. Big decisions initially are about platinum, whether we approach patients with cisplatin or carboplatin. For most patients with this extensive stage, I'd say the field has shifted more towards carboplatin. But getting them squared away and started on chemotherapy quickly and addressing their comorbidities are probably the largest of our challenges.
Right, so I mean, most of the patients that we do see end up are extensive stage disease, sort of, I guess, 70-30, 80-20, extensive limited stage disease. And we often, their first presentation might be, a hospital admission for pulmonary problems, so you're starting chemotherapy in the hospital. It's not uncommon for these patients to have a lot of liver metastases and a bilirubin of 5. What do you do for patients that have compromised organ function, and how do you handle those situations?
I mean, starting chemotherapy quickly, often it requires dose adjustments, dose modifications for that organ function. But the key here is speed, getting them staged as quickly as possible, biopsied as quickly as possible, and treated.
I think that's right. I mean, from my experience, unlike non-small cell, where maybe you could wait and start them on treatment in the following week, they need to start like the same day or the next day. So let's say we do, have a patient that we start on chemotherapy for extensive stage disease, and they have a nice response to therapy. I mean, Taufeeq, maybe you can give us your approach in terms of the number of cycles of therapy that you use, which platinum you use, whether you use PCI in extensive stage patients, whether you use consolidation chest CAR T in patients. So once you get through that initial hump, where do we go?
Yeah, thank you, Naiyer. I think my approach with a lot of our patients with small cell, as Jamie already alluded to, is to get them on treatment as quickly as we can and as safely as we can. From my own experience treating these patients over time, I've tended to go with the minimum amount of chemotherapy that will get the job done because they're generally frail with a lot of comorbid illnesses. As we know, this is strongly associated with tobacco use, so this patient will come with a lot of cardiac as well as pulmonary compromise. And I tend to go with 4 cycles of chemotherapy for majority of my patients with extensive stage disease. Very rarely do I go out to 6 cycles. Occasions where I've done that generally have been younger patients, probably in their 40s with limited comorbid conditions, who benefited strongly after 4 cycles of treatment with ongoing response. And I tried to give them just 2 additional cycles, more as insurance against something bad happening very soon. But for the older patient, I go, in general, on average, 4 cycles of chemotherapy. With the choice between carboplatin and cisplatin, I think, while we've never had a head-to-head comparison of this agent to say which one is better, the received wisdom has always been that we thought cisplatin would be better. But if you actually look at the COSIS meta-analysis, which looked at close to 700 small cell lung cancer patients, some of them treated with cisplatin, some treated with carbo, there did not seem to be any survival difference between them. So I've tended to go with carboplatin for majority of my patients. Having said that, there are unique patient features that will make me consider cisplatin. When you have extensive marrow replacement with a lot of cytopenias, that will be one instance where cisplatin perhaps will lend itself better in terms of anticipating likely toxicities.